So let's start. Part second, day 2, virtual CME of early pregnancy scanning. We are right now broadcasting through Zoom on our Facebook page, and we are live on YouTube also. If you want our regular updates on our of our courses on our Facebook page and our YouTube channel, you can subscribe to our channel and you can join our Facebook page as well. I am displaying the links. For Facebook, you have to search the page, and that is Bilmed Ultrasound Training Courses. So once you will go to Facebook, you have to search for the page, not the group. And that is by the title of Bilmed Ultrasound Training Courses. And on YouTube, our channel is by the title of Bilmed Ultrasound Institute only. So for YouTube, it is Bilmed Ultrasound Institute, and for Facebook, it is Bilmed Ultrasound Training Courses. So, starting the session. And let me remind you again that this is not a training course, whatever we are taking right now, but is the CME, virtual CME only, which we are taking. This whole early pregnancy ultrasound via our server, the complete course is of 30 to 40 days, and we are now taking a virtual CME of early pregnancy, and today is day 2. So now let us see where we left yesterday. So yesterday we discussed a bit about embryology. These are the points which we discussed. Embryology. Then we discussed this very, very important. I am using word twice, very, very important slide of early pregnancy. So this is already discussed. Then we discussed the double decidual sign. We discussed the unobliterated uterine cavity. We discussed this is the double decidual sign which we discussed yesterday, and these are the pictures which we have yesterday discussed with you. So this is the left behind unobliterated uterine cavity, which is also discussed yesterday. Shreya, settle this. Settle the mic. So we discussed yesterday. Okay, done. So we discussed yesterday the oligoamniotic sacs, and we discussed how important this oligoamniotic sac is, why that is important. So this all is discussed with you. Now, today's session. Today's session is subchorionic hemorrhage, a bleed. Give me the pointer. So this bleed, subchorionic hemorrhage, take it out and drop it again. There is some technical glitch. We are fixing that. Okay, leave this, leave that. Okay, I will do. Now, whenever we are seeing any hemorrhage, any detachment of gestational sac, we have to be very clear that where is that hemorrhage? Is that hemorrhage at the site of placentation or away from the site of placentation. Now, you might be thinking we are discussing early pregnancy and how I can see a placenta in early pregnancy. I will come to that. What I'm using word is the site of placentation, not placenta itself. Now, the point here is that if the blood, if the detachment is at the level of the placentation, is that more dangerous, or if it is away from the placentation site? Of course, if it is at the level of the placentation, because if it is at the level of the placentation, placental separation will occur and we will have an abruptio. But if the hematoma is detaching the membranes only, if it is detaching the membranes only, then it will unlikely reach to that size where it will detach the placenta. So the point is, if it is not at the level of the placentation, that is not very worrisome. But if it is detaching the placental side, that is worrisome. Now, you might be thinking, what is the placenta? Chorionic frontusum. The chorionic frontusum itself is the placental site. So the point is, you have to search for the chorionic frontusum. Now, how that chorionic frontusum is looking on ultrasound? That chorionic frontusum, we are having decidual reactions. Wherever there will be more of decidual reactions, try to understand, wherever there will be more of decidual reactions, that is the site of placenta. Now see over here, I am having more decidual reactions as compared to this area. It means that the placental site is here in the posterior area, not in anterior, and the detachment is anteriorly. So the important point is that not only you have to label that I am dealing with the detachment of this much cc, 20 cc, 40 cc, 2 cc. No, volume is important, but what I am trying to say that more important is the location. Okay, so not only you have to give the volumes, but the location also. So again, repeating, C for the chorionic frontusum, and if the chorionic frontusum, if the hematoma is at the level of the placental site, that is more dangerous. See to the camera. That is more dangerous than if it is away from the placental site. Now the yolk sac. Yolk sac is the next one. Yolk sac is the God's given tiffin to baby. Baby, take this tiffin and go to the world. Now the point is, if yolk sac is abnormal, there are high chances of that you will be losing that fetus. Now the point is, we are not giving sufficient time. To yolk sac. Please give sufficient time to yolk sac. So yolk sac, you have to scan in each and every early pregnancy. The point is that what I have to see in yolk sac, is that jet black. That should be jet black only, and the shape has to be round only, not oval, not wrinkled. It has to be round only, like this. And the inner circle, what I mean by circle is this yolk sac center has to be jet black only. Now, yolk sac is, how much is the yolk sac? Yolk sac diameter between 5 to 10 weeks is 5 to 6 millimeters. So roughly it is about a 5 millimeters. Yolk sac should not be big enough. It should not be very small. How much is, if it is very small, we will come to that. So the point is, don't get happy if you are dealing with a big yolk sac. It doesn't mean that God has given a bigger effort. No, that is also abnormal. Now, see here, the yolk sac should not be less than 2 millimeters and it should not cross 5 millimeters. So yolk sac has to be in the bracket of 2 to 5 millimeters only. Now, it confirms the intrauterine pregnancy. It means that if you are dealing with a gestational sac with a yolk sac, it cannot be a pseudo-gestational sac. So, in fact, this yolk sac is the first structure which is visualized in the gestational sac, even before visualization of an embryonic disc. So, as already said, first structure it is, and it at times it diagnoses the embryonic demise. How? If you are dealing with a very abnormal yolk sac, very abnormal yolk sac. What is abnormal? We will come to that. It means that you are dealing with a dead fetus. In 99.9% of cases, the fetus will not have the fetal cardiac activity. So, this is the yolk sac's importance. Now, I told you it should not be more than 5, and if it is more than 6 millimeters, it is too large. So too large is also abnormal, and the assessment to spontaneous abortion prediction is the specificity, I mean, is about a 97% over here if it is too large. And if it is too small means if it is less than 2 millimeters. See the specificity again, more than 90, it means 95% of specificity with a small yolk sac. Now, irregular shape. These are the things which we have to see in yolk sac. Irregular shape, mainly these wrinkled with indented walls, degenerative change, abundant calcifications. So if you are having a calcified yolk sac, that is also abnormal. So if you are able to put a Doppler, and if you see that, so before Doppler, the number of these yolk sacs, usually if you are having more than one yolk sac, if you are having 2 yolk sacs, it means that you have to search for the second fetal pole also. Now, summing up, yolk sac should not be less than 2. It should not be greater than 6 millimeters. It has to be jet black center, I mean. The wall should not be calcified. And the next point is, it has to be round, round, and round only. No oval, no hexagonal, no shape is accepted except the round shape only. Now, in normal yolk sac size, 5 to 6 millimeters. Abnormal, greater than 6, less than 2. Please keep on noting these points. Shape, as already said, round, not oval, no distortion should be there. If it is oval or distorted, that is abnormal, that is abnormal. Now, echogenic rim with hypoechoic center, it means that the walls are hyperechoic and the center is hypoechoic. And if we are having a hyperechoic wall, that is calcified wall, that is abnormal. And if you are able to put the Doppler, absence of diastolic flow is there in normal, and if you see an irregular blood flow, that means that the venous pull up is over there. It means that the congestion has occurred over there. That is also abnormal. So please note down these points for normal yolk sac and abnormal yolk sac in your notebooks. Now, Now the embryo with a cardiac activity. Everybody's eyes are directly going on to the cardiac activity, whether I am dealing with a live embryo or a abnormal embryo. You don't have to see only fetal heart. You have to see many things before, like the double decidual sign, whether I am dealing with an intra or an extrauterine pregnancy, I mean the pseudo-gestational or a true intrauterine pregnancy. Then I have to see for the DDS, that is, and the unobliterated uterine cavity. Then I have to see for a knee detachment, which we have discussed now. Then we have to see for the yolk sac, whether this is a normal yolk sac or an abnormal yolk sac. Then we have to see for the cardiac activity. The point is not only the cardiac activity to start with. You are having multiple things which you have to see in the fetal heart rate. The important point, what we have to see, not only you have to see for the fetal cardiac activity, whether it is present or absent, but you have to trace it. What I mean by trace, you have to see how many beats per minute. I am not very much worried about the fetal tachycardia, but I am more worried with a fetal bradycardia. Now let us see what fetal bradycardia means. Fetal heart rate, please note this, fetal heart rate of less than 80 beats per minute in an embryo with CRL of less than 5 millimeters is having a high embryonic demise. It means that if CRL is less than 5 millimeters and I am dealing with a 80 beats per minute, it is having a how much? 60% risk of demise. So in between 80 and 90 beats per minute, it is having 60% of risk of demise. Now see the importance. If everything is apparently normal, but fetal cardiac activity is also looking pulsating fetal heart, but the point is it is not pulsating more than 90, it is say 82, 83. More than half you will be losing, because 60% is the risk over there. Now, if it is in the bracket of 90 to 99, even the risk is there, 32% of risk is over there. Now, even if it is 100, still there is 11% of risk. Now, what is normal is that I should have more than 100 beats per minute when I am dealing with a CRL of 5 millimeters. Please note these points. Now, as embryo is increasing in size, I mean, when the CRL is now in the bracket of 5 to 7 millimeters, the heart rate of 100 is associated with an abnormal, because here I should have more than 120 beats per minute. More than 120 beats per minute. So with an increasing CRL, the fetal heart should also increase. So the point here is that not only to label whether I am having a fetal heart activity pulsating plus or minus, no, you have to correlate. You have to correlate the fetal cardiac activity with CRL to label whether I am dealing with a fetal bradycardia or not. So, missed abortion. Now, what is a missed abortion? Everybody is very clear with this. Whenever there is no fetal cardiac activity. But more important is that sometimes we are getting confused whether there is a muffled fetal heart. For example, there is a muffled fetal heart. You are not getting very confident. You are not confident at that time whether these are transmitted pulsations or the fetal cardiac activity itself. Then simply put your fingers onto the maternal pulse, and if it is 72 beats per minute, and if that muffled fetal cardiac activity in inverted commas is also corresponding with the maternal pulse, then these are the transmitted pulsations, not the fetal cardiac activity. Point number one. Point number second, now see in this case, I am searching, for example, I am scanning this, I am searching for the fetal heart, I am not getting, I am now confused whether to label this as missed abortion or not. Why not to go to the Yolk sac? I'm your doctor scanning, how are you, Yolk sac? Yolk sac will tell you, I am very abnormal. Now, why this Yolk sac is abnormal? See, I'm zooming on this. Why this Yolk sac is abnormal? Because there is lot of calcifications. So the wall is calcified. So am I proving that Yolk sac is helping you out? But you should know how the Yolk sac will help you. So Yolk sac is telling that the embryo, the fetus right now is a dead fetus. And mind my words, and if this fetal is alive, if this fetus is having 120 beats per minute, but in a setting of this Yolk sac, I am having very, very bad prognosis. I will rescan that patient. If in this fetus, fetal cardiac activity is present, for example, if it is present today, there are high chances that it will not be present tomorrow or a day after tomorrow. Because Yolk sac is telling me that I am calcified, my walls are calcified, so I am an abnormal Yolk sac. Please consider me in your diagnosis. So anyhow, missed abortion is whenever you are not having any fetal cardiac pulsations. And please, at that time, when there is no fetal cardiac pulsations, see to for any detachment. See to for an abnormal Yolk sac. And if you got any detachment or abnormal Yolk sac, then you are on right track. That is the point. Now, blighted ovum and embryonic pregnancy means that there is no fetal pole, and embryonic, there is no embryo. And if there is no embryo, then that is a blighted ovum. So these are some pictures of blighted ovum. In this blighted ovum, usually I will be having a less of decidual reactions. A less of decidual reactions. A normal decidual reaction is more than 2 millimeters. Now, in that blighted ovum, I may have wrinkled walls over there, wrinkled walls, see over here, wrinkled walls over here. So that is blighted ovum. Now the decision making in early pregnancy. We will be showing you patients also today. We'll be showing you patients. First, embryo, if visualize it, and if visualize it, what is the what is cardiac activity? Status of cardiac activity, I mean. If cardiac activity is present, then next point is that what is the status of Yolk sac? Now see, what is the status of Yolk sac? Is Yolk sac present and normal? Not only present, Yolk sac present and should be normal. Then only everything is normal. And cardiac activity present means that cardiac activity present and normal. Please read as normal also. Normal word is absent over here, but read it with cardiac activity present and normal, Yolk sac present and normal. Then only that is an normal pregnancy. Fetal heart rate, normal, routine, obs. Now, if fetal cardiac activity is present and normal, now see, cardiac activity present and normal, then you have to see for the Yolk sac. If Yolk sac is absent or abnormal, what you have to do? Close follow-up. Yolk sac absent, that is very much abnormal. Now, next is the fetal heart rate. Fetal heart rate, if abnormal, now you know what is abnormal. Abnormal is that if it is not correlating with CRL, which we have just now discussed, then you have to again take a close follow-up. The point here is that not only you have to visualize the gestational sac, not only you have to get happy that there is a fetal pole with a pulsating fetal heart, you have to see many more things besides these only two things which you are more concentrating on. Now, cardiac activity if absent. Now, what if cardiac activity is absent? The CRL should be less than 5 millimeters, and if it is more than 5 millimeters, then that is missed abortion. But if it is less than 5 millimeters, I'm giving you the benefit of doubt. Maybe that you have missed it, or your machine is not resolving the things very clearly, or your scan plane is not cutting properly, and your machine is not adjusted. There are a lot of things you have to do with the machine. That is in our physics and machine settings course. Then you have to see whether the scan plane is cutting through that. Okay, I am giving you the benefit of doubt. If it is less than 5 millimeters, you can rescan. But if it is more than 5 millimeters, that is a missed abortion. Now, if CRL is less than 5 millimeters, you can take a follow-up scan after 1 week. And if it appears, maybe that you have previously missed that, or maybe that you are dealing with a late conception. That is why the fetal cardiac activity was not seen previously. So the point is that you have to scan each and everything what is discussed. You have to first see where is the yolk sac and what is the status of yolk sac. But before yolk sac, you have to not always jump onto the gestational sac. You have to think that maybe that I am dealing with the pseudogestational sac. These pseudogestational sacs in ectopic pregnancies, are seen in about 20 to 40% of ectopic pregnancies. So by the help of the double decidual sign, by the help of that unobliterated uterine cavity, you can make out that I am dealing with a North Pole or South Pole. The pseudogestational sac or a true intrauterine gestational sac. Then if the yolk sac is over there, then it is confirming that that is not a pseudogestational sac. Now, coming to these hematomas, the hemorrhage, you have to see it with respect to the placental site. If it is at the level of the placental site, there are high chances or that you will be losing that pregnancy. But if it is away from the placental site, the chorionic frontusum, the prognosis is good. Now, the yolk sac you have to see. We have discussed in detail that yolk sac. Then lastly, you have to see whether the cardiac activity, not only present, is correlating with the CRL or not. Then only the early pregnancy scan is complete. So this was all about the early pregnancy scan. But this is not the end. This is not even the beginning of the end. I will say that this is end of beginnings, because we have still a long way to go, because this ultrasound is not very simple and it is not easy. We are not in photography that we'll be putting the probe and everything will be reflecting on screen. We have to put our theory in action. We have to put machine settings. We have to put bit of physics also. And in gynae, we have to have a clear understanding of gynecology and early pregnancy, a bit of embryology. Then only you can scan. Now, let us go to the MCQs now. After this MCQ session, we will take a 5 minutes break. Then we will show you some live patients today. So these are some questions which we have discussed yesterday. Not all we have discussed yesterday. We have discussed half yesterday and half we will discuss today. Okay. Yeah. We have discussed up to 18th probably. No, up to 12th only. Okay, 13th question. 13th question reads as, The herniation, now see, the herniation of embryonic bowel into the base of the umbilical cord at 9 weeks is physiological bowel herniation, pseudo-omphalocele, omphalocele, or gastroschisis. In your comment boxes now, A, B, C, or D. Zoom participants in your comment box, those who are with me on Facebook and YouTube, they can also comment in the appropriate comment boxes. Hit it now, A, B, C, or D for 13th question. Hurry up. Show me the comment box. Okay, I will take, wait. Okay, Dr. Anusha A, Dr. Harjinder A, Dr. Taya A, Dr. Leena A, Dr. Chandra A, and A's are coming over there. Yes, very good. Physiological midgut herniation is seen about from 8 to 11. I will say from 8 to 11, it is visible on ultrasound screen, but it should not be beyond 13 weeks. If it is beyond persisting beyond 13 weeks, then it is abnormal. Otherwise, that is a normal finding. Okay, 14th question. The most common pelvic mass associated with pregnancy is, try to understand the question first. The most common pelvic mass associated with pregnancy is uterine leiomyoma, dermoid cyst, thecal luteal cyst, or corpus luteal cyst. A, B, C, D. For 14th. For 14th. Hurry up. 2 more seconds. Dr. Anusha again, corpus luteum, Dr. Coco, corpus luteum, Dr. Mardula, corpus luteum, Dr. Taya, Dr. Sarika, Dr. Komal, Dr. Nipura, everybody is with D, that is corpus luteum. Very good. So that is the corpus luteum. So the most common pelvic mass associated with pregnancy is the corpus luteum. Now, 15th question. All of the following are associated with an abnormal knuckle translucency. Read the question properly. All of the following are associated with an abnormal knuckle translucency except trisomy 21A, B is trisomy 16, then C is trisomy 18, and D is the Turner syndrome. A, B, C, D for 15th. Five seconds, 5 more seconds. See, except is here, except. All of the following are associated with an abnormal knuckle translucency except. Only one right answer. I got about 20 answers. Dr. Anusha, Dr. Sonu, Dr. Uma, Dr. Anusha. No, it is not D. Dr. Shilpa, it is not D. Dr. Chandra, it is not D. Dr. Miridula, you hit it right. It is B. Yes, it is B. Trisomy 16 because except is written over here. Next question. The most common, that is the 16th question. The most common cause of pelvic pain with pregnancy is, the most common is written over here. The most common cause of pelvic pain with pregnancy is A, ectopic pregnancy, B, heterotrophic pregnancy, C, missed abortion, D, molar pregnancy. Common cause, common. Of pelvic pain with pregnancy is. Yes, an easy question. Dr. Deepa, Dr. Shilpa, Dr. Ritu, Dr. S. Taya, Dr. Nida, Dr. Komal, everybody with A, missed abortions. Very good. 17, the most common location of ectopic pregnancy is, now see, the most common location of an ectopic pregnancy is A, ovary interstitial portion of uterine tube is B, C is the coronal portion of uterine tube, D is the ampullary portion of the uterine tube. 17th question. Hurry up. Yes, everybody is hitting it right, except one only. It is the ampullary portion of the uterine tube. 18th question. All of the following are sonographic findings consistent with ectopic pregnancy, except this is the last question. For 18th, is it A, decidual thickness, B, complex free fluid within pelvis, C, bilateral multilocular ovarian cyst, D, complex adnexal mass separating from ipsilateral ovary? 18th, question number 18th, A, B, C, or D? Dr. Priya, Dr. Manish, Dr. Nida, Dr. Komal, Dr. Irfan, Dr. Anusha, Dr. Deepa, and Dr. Urvashi, Dr. Sonu, Dr. Chandra, Dr. I am having many answers here, many comments rather here. So I am very sorry if I will be skipping some. Everybody is with C. Now see, for 18th, it is C. Yes, bilateral multiloculated ovarian cysts, because it is except written over here. Decidual thickness is there, and complex free fluid within pelvis is there. Complex adnexal mass separating from the ipsilateral ovary is there, but bilateral multiloculated ovarian cyst will not be there. So on here, after this slide, I will be having questions of ectopic pregnancy, because we have not discussed ectopic pregnancy, so we will not be taking the ectopic pregnancies. So this is all for now. And again, reminding you to subscribe to our YouTube channel. You can search Bilmed Ultrasound Institute, Bilmed Ultrasound Institute on YouTube, and on Facebook you have to search for Bilmed Ultrasound training courses. So you have to subscribe, and you can like our Facebook page to get regular updates of our these CMEs. And this, whatever we are taking right now, is not a course. I am again repeating, this is not a course. Whatever we are taking, our course is much more detailed than this virtual CME. Now we will take a 5 minutes break. Then we will show you some patients, live patients. I will show you how that is our job, how we will show you those patients. So in next session, we will show you patients. So we'll be resuming after 5 minutes.